Good afternoon, everyone, and a warm welcome. I'm going to give it 1 to 2 minutes just to allow people to settle in. I think the last numbers I received was we're nearing about 350 registrations, of which there are close to 200 chiropractors, chiro interns and students, and then there's also well over 100 physiotherapists who registered. I was very surprised, and it's welcoming you all to get registrations from even a few podiatrists, a few psychologists, and biokineticists. I really hope that this afternoon will be very informative and that everyone's going to at least take some piece of information away with regards to the risk management of dry needling. But here to talk to you today are two old hands at dry needling. And gentlemen, please note, I didn't say you are old, so don't blame me for that. First of all, we've got Bruce Barker, who's a physiotherapist at Luke and Barker Incorporated. And Bruce is also the director at Optimal Dry Needling Solutions. Now, Bruce, you've got a very special interest in dry needling, and you also do some teaching, is that correct?
Yeah, we run dry needling courses here in South Africa, in Southern Africa, in the States, in the Middle East, and in Europe. With any luck, we'll be in India in 2 months' time as well. So all over the world, we run the dry needling courses.
Oh, fingers crossed that's a success for you.
Yeah.
Well, welcome and thank you very much for joining us today.
Thanks.
We've also got Dr. Brad Beira. Now, Brad is a chiropractor and also a medico-legal expert. And Brad, I'm wondering, what's your involvement with dry needling? You do it in your practice, or are you here more because from a medico-legal side of things and the consent side of things?
Lonnie, hi. And hi to everyone. I'm here for the coffee, really. I learned dry needling and studied it back in the mid-90s and worked with it in my practice until the early 2000s. And recently I do a lot of work on the medico-legal side of what do we need to know about fine filament work, what is dry needling, what does it include in it, what doesn't it include, and importantly, how do we defend a position when we as a practitioner versus how a patient sees the journey. So I'm going to talk today specifically more on the medico-legal and legal side and leave the technical clinical side to Bruce. And we'll see between the three of us, the two physios and one chiro, how we can balance the conversation.
Excellent. Well, I can't call myself a physio anymore. I haven't treated patients in quite a few years. But for those that don't know me, my name is Lani Ace. I'm a product manager with the SpaceNet Global Group. And ProfNet is one of numerous companies that forms part of this group. Now, as you may know, ProfNet recently partnered with Shackleton Risk Management, with Genoa, and with Sapphire, who've created a range of new medical professional indemnity policies. And I would just like to thank Shackleton, Genoa, and Sapphire to help you, the healthcare provider, manage the risk in your practice. If you have any burning questions, I'm sure you can use the chat functionality, and our guest speakers will keep a close eye on those, and let's see if we can answer and assist with some of your questions. But guys, I do think we need to start. It is 3-4 minutes past 6 o'clock already. I don't want to keep everyone waiting. And as I was preparing for today's webinar, I was literally thinking, when last did I use dry needling on a patient? And this was literally dating back to about 2006, 2007, when I was working in the UK. I also trained as an acupuncturist there, strangely enough. But Bruce, I think while we're talking about dry needling specifically today, maybe you can start the conversation with a definition of what dry needling is, please.
Yeah, well, good evening, everybody, and thanks for attending this webinar. If we look at acupuncture versus dry needling, we're looking at essentially a clash of diagnostic systems as well as a comparison of the technical intervention. The diagnosis for any traditional acupuncture or traditional needling system will have to bear in mind the diagnosis, the system of meridians, the system of energy lines and points on those lines. So the diagnosis in acupuncture would dictate the therapy that you're going to embark in. The points that you use will depend on what the diagnosis is. You might end up needling someplace on the patient's ear, as well as their hand, and maybe somewhere on their back to treat a particular condition. The treatment places will be related to your diagnosis within the traditional system. And that's now very different to a Western or scientific approach to the body, where you would essentially be using the needling, again, because of your diagnosis, but at a local trigger point for the most part. The needle themselves are the same things. A tool is a tool, but you don't define the discipline by a tool. The techniques that you'd use for acupuncture are very static, mostly, where you would insert and maybe rotate the needle and leave it there for a length of time. Whereas with the modern trigger point dry needling or intramuscular dry needling, you would insert the needle multiple times in a fast in and out fashion to elicit multiple local twitch responses. So there's a technical difference, and there's a kind of a philosophical or diagnostic difference too. Hope that's helpful.
All right, I think that really answers the question. Brad, is there anything from your side? I know obviously physios register with Health Profession Council, the chiros with the Allied Health Profession Council. Is there a difference with regards to the approach?
Yeah, great question, Lonnie. And I think if I can start that by just building up on Bruce's comments, let's take and acknowledge acupuncture for the registered profession that it is, and the professional clinical approach that it has. Let's park that to the side for now, and let's talk specifically about dry needling. So there is an act that both the health professions and allied health professions councils are subordinate to, which is the National Health Act. So everything that both professions do has to fit under the National Health Act and the prescriptions of that act. And then underneath that, they have to fall into the scope of practice of either the Health Professions Act or the Allied Health Professions Act. Now, when it comes to dry needling or fine filament treatment, whether it's a static or dynamic approach, because both of those approaches occur, there are codes or guidelines, clinical guidelines. Now, Bruce will probably talk a lot more about this later, but there are physiotherapy guidelines that were published in 2017, and there were chiropractic and allied health professions guidelines that were practiced in 2020. Now, these guidelines say the same thing, by and large. It's around, I call them the scary areas and the scary muscles, and the things to be aware of. And Bruce had a chuckle with me when I spoke about scary areas yesterday, and we'll unpack that later. It's about adverse outcomes and complications, and we'll talk about that a little bit. It's about the clinical approach and the journey, which is, in fact, the references in those two guidelines are the same references, because there's only so many books and authors who are considered to be well-versed or authorities in this area. So the guidelines are ostensibly the same. The approach is the same. The difference in the approach is how we spell chiropractor versus physiotherapy. But the technique should be consistent across all. And the important thing, and the reason that I say this, now I'm going to put my medico-legal hat on, is the law doesn't distinguish between the registration of the practitioner. It distinguishes between whether the technique that was applied has the outcome that would be expected of the reasonable practitioner. And because dry needling is a therapy that's globally standardized and largely homogenized, regardless of your professional approach, you should have the same outcome with the same technique. Bruce, your thoughts on that?
Oh, very interesting. Yeah, very interesting, Brad. Thank you for that. Bruce, if I may interrupt you, while we're talking about guidelines and dry needling standards, there are two links that I'm going to share with the audience. I'm pasting it in the chat functionality where you can actually find both the physio and chiro guidelines. So I'm going to paste it now. You can copy and paste it now, and we'll try and actually share those with you again before the end of the webinar. But it is there for you if you need to copy and paste that. Sorry, Bruce, I interrupted you.
Yeah, I broadly agree with Brad on that, because you should expect the safety guidelines to be the same all over the world. Sadly, they're not. And we're quite privileged in South Africa to have both the chiropractics and the osteopathic guidelines out there with the physios. That we do accord is great. There are countries who don't have those in place. And it's actually quite a struggle sometimes to get people upskilled to prioritize patient safety. So it's great that we have those, but it's by no means universal just yet.
Mhm. Okay, so talking about safety, and we're definitely here to talk about the risk management today. Let's jump in and talk about the risk involved with dry needling. From a clinical point of view, can you all risks involved with dry needling severe, Bruce?
No, not at all. It turns out that in the literature, there are multiple classifications that you could put together, some of which are qualitative, some of which are quantitative. Now, the qualitative ones will be describing it and breaking up the adverse events into things like mild events, serious events, and serious events. You could also break it up in different ways, different words if you liked, so minor or serious. So just describing the effect that would be on the individual patient. Now, the minor ones are best described as being those short-term, non-serious events where the function is intact and it's a transient effect. But the more serious or the major ones, you could subsume as being medium to long-term effects where there's actual functional loss and you would necessitate some sort of medical intervention as well to treat that consequence. So by no means are they all serious. You can certainly split them up into things that are temporary, transient, and those which have more lasting effects.
And can you perhaps share an example under each of those categories? Are we talking about a small minor bruise under the minor category versus a pneumothorax, for example, under the severe category?
Yeah, I think that those are fair breakdowns as well. The minor ones, typically the incidence of these things is much greater. So like a very common side effect would be something which is 10% of interventions. So 1 in 10 people would experience a very common side effect. Between 1 and 10 in 100 would be experiencing a common side effect. The WHO would describe the uncommon ones as 1 in 1,000, or 1 in 10,000 for the very rare ones. Now, a very common one would be bruising, as you said, and the other end of the scale, which would be a very rare one, would be a pneumothorax injury. And the incidences are really, really small, but unfortunately, the consequence of an individual patient who does suffer a serious event is quite great. It's financially burdensome to the insurer, and it's distressing to the individual patient. So although they're very rare and the technique is very safe, there's a very real risk as well. And that's why we have to be aware that of stratifying the risk that we assume. So other examples of minor would be bruising, temporary exacerbation of symptoms, some bleeding, and those would be minor. And serious, I mean, they're so serious they end up with individual case studies being published about them. Pneumothorax are a couple of those, but things like subdural hematomas, neural injuries like radial nerve injuries, spinal cord injuries, and even there's a recorded incidence of a hemopericardium as well. But they're so rare as to be single case events, apart from the pneumothorax, which again is a very rare complication, but does exist.
Where would a temporary nerve injury fall in if you happen to nick a nerve while you're doing your needling?
Yeah, there are a couple of isolated published studies about nerve injuries. What's far more likely to happen, though, is that you end up in the mesoneurium around the nerve, which gives you that electric shooting feeling going down in the nerve distribution. Those are very temporary. It's like 24 hours and you're better. But where you actually go and lesion a nerve, then you can end up with some permanent damage. So 2 years ago, a paper published on a radial nerve injury showed no recovery after 2 years. Sciatic nerve injuries, which happen with hypodermic needles sometimes, also result in sciatic fallout. But fortunately, the type of needle that we use with the dry needling interventions is a filiform, relatively blunt needle. And you actually have to try really hard to cause a nerve lesion beyond just the mesoneurium. So actually going into the axon is hard work with a dry needling needle. Very unusual to happen, much more common that you just go into the mesoneurium to cause electric shock, and that's a transient effect.
And I mean, your patient tends to comment on that very quickly as well, and you can just pull out and direct it in a slightly different direction again.
Yeah, the mesoneurium is kind of, it works like I live in Gauteng. We do security. So it works like the beamers around your house. If some bloke breaks into your house, you'll break the beam first before he actually gets in and steals anything from your home. Breaking the beam is that same entering the mesoneurium electrical effect. Nothing's actually happened yet. The alarm's just gone off. So there's no actual consequence to that.
I think that's a really good example to use, a nice analogy.
Barney,
Brad.
can I build on that just a little bit? Because I think there's two categories of complication that we need to talk about. And I see Hester's asking this question as we speak. Do we have a classification as mild, medium, or severe in medical negligence? No, we have a classification of friendly and unfriendly. So friendly complication is the one where you can say to the person, gosh, this has just happened. You've got a little bit of itch, you've got a little bit of a bleed, you've got a little bit of a tingle, you're a bit breathless. Gosh, I'm really sorry. Let's walk through this together. Let's see that we're doing well. And you call and you follow up and you walk that patient through their experience. Those very, 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 very rarely end up as a formal complaint. The unfriendly one is where not enough attention is given to the emotional, physical, and physiological impact of that person. So I call them the 5 Ps. And this comes partly to answer this question. The 5 Ps are, it's the patient and the practitioner, you and the other person, the first 2 Ps. And then it's the physical, physiological, and psychological implications. Because you can have a very, very small bruise that the person is sitting the next day at the table because you've needled around the TMJ or you've needled into the face and there's a discoloration. And they happen to have a personal injury attorney who's their best friend and said, you're permanently disfigured. Bruce is terrible at what he did. We could probably get you a couple of million rand. And now you've gone from a friendly consultation into a potential litigation. And so that attitudinal shift is not around the complication. It's around the sentiment of the communication that gets us into trouble. I know of cases where a person's had a pneumothorax. And in the extreme case, and Bruce mentioned this, it's 1 in 10,000 to 1 in 100,000 incidents of a pneumothorax. It's 1 in 250,000 to have a tension pneumothorax or a bilateral tension pneumothorax. So it's very, very uncommon. But you can do 2 of those. That doesn't mean you have to do 100,000 patients in order to get a pneumothorax. You can have 2 and 2 patients in a consecutive motion, needling the scary spots. So you've got to recognize that you can get a person who's got a pneumothorax. You can explain to them what's going on. You can handhold them, walk them through to the ER, be by their side. They forgive you the surgical site and the small scar in the rib. Or you can have a similar patient who takes exception to your style, who doesn't feel that warmth, who ends up in a 7-year, because on average it's a 7-year litigation journey. Now, that's the difference in terms of there is no mild, moderate, and severe. There's how good is your attorney versus my attorney, and how good or bad are the, let's call them the safe practice guidelines, the SOPs that we speak about, the informed consent, your documentation, your follow-up. And I suppose that's a little bit about what today's about.
Yeah, we'll definitely get to that, but thanks for adding to that, Brad. What I also want to try and unpack here is there's obviously a difference between a normal risk, because risks involved with all types of procedures, but then surely there's an expected outcome that you can get with dry needling versus a major complication. Is there a difference between the two, Brad, or not? Are we talking about the same thing?
Yes and no, and this is the hard one, and for everyone in the audience, we spoke about what's the difference between an adverse outcome and a complication. A complication is a known, expected, and anticipated outcome. It's known. We know that you get in the car and a complication is you could have a car accident. We know that you could do dry needling and a person can have a psycho-emotional response, fall off the table, smack their head. So there are not only the known complications of when you pierce the skin with a sharp object, which is why dry needling is a procedure, not a therapy. The procedure is when you cut through the skin with a sharp object. So that's a little bit of the answer. The adverse outcome is the outcome which is unpleasant and which we didn't want. And we do get adverse outcomes. So is an adverse outcome a complication? No, a complication can have an adverse outcome. So if your procedure, if the technique that you do leads to a complication that leads to harm to the patient in a temporary or permanent way, that's an adverse outcome. The complication is known and it's neutral. The persistent harm is the adverse outcome. And then the question is, was this done as a medical error? In other words, would the reasonable practitioner doing the same thing likely lead to the same kind of unfortunate adverse outcome? Or was this an act of recklessness or negligence? And if it's recklessness or negligence, often in the law it's regarded as assault. So if you don't get the right consent and you haven't given the right information, your treatment is regarded under rule of law as assault. Now that's no longer an adverse outcome. It's still a complication that's materialized. It's still something that is created a persistent harm or perceived harm for the patient. Just the mechanism is whether you did it diligently or non-diligently.
Okay. Bruce, I see you've been sort of shaking your head and nodding along. What's your view on this?
Well, mostly nodding along. That's the good part. Nodding along. I think it's maybe helpful for us to tag some numbers onto these complications. You know, can we reasonably expect that if you put a needle into a patient that there might be bleeding or bruising? Yeah, absolutely. And to protect the therapeutic alliance that you have with your patient, which is kind of what Brad was touching on, if the patient's on side from the word go about all these possible complications, that's where we start. So if the patient knows going in and gives consent to the possible complications, that's very important. So if we take a look at something like bleeding, I mean, probably 1 in 3 dry needling treatments results in some minor bleeding. I mean, you stick a cotton wool swab on there and it goes away. Compared to bruising, petechiae, which would be like a 7% risk. Actual pain during the treatment is a 5% risk. Pain after treatment, a 2.7% risk. So these are all quite, I mean, they fall under the common WHO classification, but they're completely expected because you're piecing the skin. Where things go wrong with the major events is when you don't need to put the needle into the foramen magnum, which has happened. You don't need to put the needle into the lung, which has happened. And those would be definitely not part of the guidelines. I mean, that's just a malpractice claim. But the others, those mild ones, you must warn your patient about them so that they know going in, when they sign a consent form, these are possible complications. You can't warn your patient about things that are outside the bounds of guidelines. I mean, it would be counterproductive to warn the patient that you might needle their cerebellum in error when you're needling in the cervical area, because that's so far out of the bounds of what is proper as to be a straightforward malpractice claim. So the consent documents that we have to use for the patients should cover those issues which are likely to occur and some of the major complications which may possibly rarely occur. But you can't cover absolutely every event. You must cover the major parts so the patient understands that you're professional and that you're working through this properly and getting them on side. That building a therapeutic alliance is very important.
Can I build on that, Lonnie and Bruce? Thank you.
Please do.
Because I saw 2 questions came through,
Yes.
and there's a piece. We spoke earlier about what the Health Professions Council's perspective and expectations are. Their view is if there's a 1% chance of risk, you have to declare it to the patient. So that's number 1. Number 2 is you need to go back and read Section 6 and Section 7 of the National Health Act. Informed consent needs to be explicit. Explicit means in writing. So if you're doing a procedure that potentially can cause harm, that is invasive to the person, it has to have consent in writing. Now, that's not a health professions regulatory body or an allied health professions regulatory body position. That's a legal issue. And it's a legal issue under the Constitution, under the Bill of Rights, and under the National Health Act. Everything else is subordinate to that. So yes, you do need to have written consent. Should you bill somebody who you created a complication in? Well, let's do this both ways. You should bill them because you provided a professional service. Would you like to get under somebody's skin for one consult fee and end up with 7 years of litigation? Probably not. So you need to apply your judgment to this. My general sense is, and they do this in many of the states in the United States, is they have apology rules and say, I empathize with you. I'm hell of a sorry for this outcome. We spoke about this. We knew that this could happen. We can't write everything, but we write the logical things. So what are the effects? And I'm going to just generalize for a moment. Patient comes to see me, Lonnie, it's you because Bruce pushed you down the stairs, or you tripped because you were running away, or whatever the case may be. And now we decide that you've got a upper trapezius myofascial trigger point pain and a cervicogenic headache syndrome, blah, 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 blah. So we decide to needle you. I need to say, one of the risks of needling is fainting. You might have a sympathetic seizure as a consequence of this. And if you have a sympathetic seizure, I don't have to say you could fall off the bed, hit your head on the corner, and end up with a laceration, which I did see happen once in a case in Miami, where the patient sued the doctor. And not only that, but the patient's family member had an issue. And because the family member had an issue and they fainted and they got hurt, it created that. So I do agree that there's points of reasonableness. But informed consent is not only the document that you sign, it's the entire patient journey from the minute they walk in until after you follow up with them post-treatment. Now, we spoke about this recently. Informed consent is not only the form. And when Bruce, Lonnie, and I spoke about this in preparation for today, I used the example of every new patient I see. I contact that evening and I ask them how they are. Now, that's part of the natural follow-up that you would expect from a reasonable practitioner. If you do a needling procedure that has elicited a pain response where the patient says, I'm uncomfortable, I feel a bit sore, I felt a bit nauseous, I felt a bit dizzy, I have a paresthesia, my finger, my thumb and my index finger tingled and went numb for a second. You know, the reasonable person would be expected to call up an hour or two later and say, Lonnie, how are you feeling? That tingling still there? Yeah. Now, if I send you a telehealth bill for that, how are you going to respond? So use your judgment, because there's a fine line of judgment here. Do people need to sign their consent every time? No, I don't believe that to be true, but I do believe the following to be true as a guideline. And I want to say this because I just want to dispel a myth. It's not the insurer's requirement that you do informed consent and communicate with the patient. It's the Constitution, it's the National Health Act, it's your registration as a practitioner for your legal requirements. It is your ethical requirements and your social requirements, what we call your ESLI requirements, to follow up as a good practitioner and a reasonable citizen. So there's no insurance requirement that you do this. But if you don't do written consent in a reasonable way, and you don't follow up with the patient in a reasonable way, it's very, 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 very hard to defend you when a patient's attorney asks somebody like me or somebody like Bruce to write a report on our impression of findings, which we get to do. And sometimes when I see some of the clinical notes or the absence of clinical notes, my eyes bleed, because there's no way to defend you. You say you did this, but your notes don't say that. You said you followed up and the patient says you did this. You need to use what they call contemporaneous notes, in whichever form you do. So that was a comment. And then there was a question around how often do they need to do it? My belief is this: if I'm seeing you for a course of treatments and I know that I'm going to be doing dry needling on your shoulder girdle or your gluteal region, or you can pick your region. The first time I see you, I explain to you that we're going to do a range of therapies that include dry needling. The alternatives are PNF, ice and stretch, interferential current, ultrasound, massage, referral to Bruce because I'm too scared. You go through that whole journey. If you reach consensus and you're now doing that treatment, for that entire scope of care, you only need one consent. If you then move from needling the belly of the semimembranosus to needling this semispinalis capitis, well, guess what? That's a different region. Those are different complications and different risks. So if you move to a different region, it would be prudent to do a different set of consent. Just like if you go in and you have a knee arthroscopy and then you want to have a shoulder repair, you're signing different consents because they're different parts of the body. So how long does a consent remain viable? Generally, and I'm answering Lonnie just this last question, generally for the scope of that treatment. So if you've seen a patient and you haven't seen them for 6 months, it would be prudent when they return to go through consent again. If you're seeing them every week or 2 or 3 times a week, and you've gone from acute to subacute to a chronic case, and you have ongoing care where you're seeing them regularly, once a year you should go back through and say, we've been through this, it's old hat, but guess what? We're just refreshing this with you. What would you want if you saw somebody on a regular basis? They may say, yeah, doc, I know this, I'm bored. Can we just get on with the treatment? And you say, sure, but please understand that life has changed. I saw a young woman today, and 10 years ago, 15 years ago, we didn't have a post-concussion syndrome. 20 years ago, post-concussion syndrome wasn't something we worried about. Now, if you don't check for post-concussion syndrome and start considering vestibular rehabilitation, you're negligent, whereas then it wasn't there. So when we started in practice, especially some of us who are older than Lonnie, like me, consent wasn't what it is now. So you manage it like it is. There was a question, and Lonnie, maybe I should hand over to you. In the past, we were told we should never admit guilt by apologizing. It's not about insurance won't cover you. There are certain, so I'm new to this. This is my 17th year of doing medico-legal insurance-related defense work. So I'm still learning this. And like Bruce, I've done this here in North America, in the UK, in the European Union, and in the Middle East. The issue for me is this. Quite simply put, you need to be prudent and you need to be careful. And if you apologize reasonably, if you say to the person, which I hear sometimes, this was absolutely my fault, it should never have happened, I made a mistake, and my insurance will cover this. You're going down a rabbit hole of hurt and harm. But to empathize with the patient, I'm hell of a sorry, this hurts. You must be really uncomfortable, and I know that it's not desirable. Let's work through this together. That's very different from saying, don't worry, my insurance will cover. And that's where insurance brokers, practitioners, and insurers in the past have said, admit nothing. The problem with admit nothing is it's really nice for people like me, because then it's litigate everything.
Sure. Sure. So perhaps just to sort of re-emphasize something that you said earlier on, consent needs to be explicit, meaning it can't be verbal. And if you change from one region to another region on the body, you need to get a signed consent form again. Is that correct? Because there was a question again about verbal consent.
Correct, because it's different risks. And I'll be quite specific. If you are needling the area in the groin or the buttock, you've got the risks of the sciatic nerve, you've got the risks of the soft tissues, you've got the bladder, you've got the urethra, you've got the urethras, you've got all of those issues. Now you move up into the cervico-thoracic junction. You've got a very different scope of risks here. You've got brachial plexus, you've got lung, you've got carotid artery. You need to explain that to people. They need to understand that needling into the gluteus maximus and needling into the sternocleidomastoid have an entirely different host of risks. And you can't do that on one consent form because it's not convenient to pause. And I'm still in practice. I know what it's like. It takes 2 or 3 minutes versus 60 months. Choose which one works for you.
Agreeing, Bruce?
Yeah, absolutely. A couple of things on the consent form. There are some standardized consent forms which are available for download. I think Chiropractic Association has one. There's one on the ODNS website as well. And I would really enforce what Brad is saying. You need a written informed consent. The information about what's happening with the event, with its complications as well. And you need to get that for every individual therapist. Maybe you've got multiple therapists in your practice. Specific person, specific area for a specific condition every time. If your treatment lapses for more than 3 months, get another form. Brad is correct. It's a 3-minute quick and easy to do a good proper job versus a nightmare. So just do it. Written informed consent is mandatory.
absolutely best practice to do that. So by the sound of things, that is one of the first risk mitigating strategies that you need to apply in your practice, is get a written consent form in place. What are some of the other risk mitigating strategies that we can follow? I'm thinking SO.
Okay, so you're breaking badly there for a second, but I take it that you're asking other risk mitigation strategies. A couple of things spring to mind. Make sure that you're allowed to do dry needling legally. It's got to be within your scope of practice. There are people who contact us all the time, massage therapists, sports massage or beauty therapists. None of those guys are allowed to do dry needling. So got to be legally allowed to, have to be properly trained to do it as well. So evidence of training in the appropriate technique. So tick those big boxes. So that speaks to being prepared for doing the technique. So make sure you're legally prepared, technically prepared. You've got the correct needles, the correct sharp spins, all those things on hand. If you walk in being prepared and your patient is prepared and you've got your consent done, the battle is half done, because really dry needling is not hard to do, but it is hard to get it. It is easy to get it wrong. So if you do the preparatory work, the skills and all those things in place, that should be half the job done. And then depending on the individual region that you're working in, the thoracic region appears to be a bigger region, a lot more responsible for serious events, whereas the lower limbs and things for the minor ones. So pay a careful attention when you're working in the thoracic region, or especially the scalene area, leave it alone. The trapezius area, pec minor, the rhomboids, those things. Now be aware of the literature as well. I mean, there are some really strong papers out there using ultrasound guided measuring tools to say exactly how much space do I have between the skin overlying rhomboid and the visceral parietal pleura, which is obviously speaks to mitigating the risk of needling into the pleural space. If you're up with the literature, you'll find out that, you know what, a 25 millimeter long needle is plenty for that area. The average distance is about 1.9 to 2.5 centimeters only. So if you're using a 25 mil long needle, according to literature, based on ultrasound studies, you're up there with the safety. So be prepared, keep up with the literature. Those are great tips.
Yeah. Can I build on that, Lonnie, Bruce, if you don't mind? Also be aware, because you use the 25 mil example. If you're needling into the scapula, understand that there are these things called anatomical variants. So not every scapula is bony. Now you're happily needling away, and guess what? You're needling into the pleural space, and you think you're doing well, but you're actually not. If the person is lateral recumbent versus prone, makes a big difference. And Krailing asked a question, and I hope I pronounced your name right. You said, well, what happens if the patient gets up and takes a phone call? I say to the person, I take the needles out, I say, cheers, we are done with this therapeutic relationship because you've got no respect. And I say that now, that's the end. The beginning is, what are my expectations of you as a patient? When you come in and you sit with me the first time around and we do the first case history, I don't know how you do it for you, but those of you that know me will be rolling your eyes and smiling. I know Dion's in there laughing his head off as I say what I say. I say, these are my rules of this practice. This is my expectation of you. And then I refer them, and those of you that know this, the Ethical Guidelines Booklet 3, there's something called the National Patients Charter. It's the Charter of Patient Rights. And it's what is everyone supposed to do as a patient. Some of that is comply with the reasonable expectations and the role of the practitioner. Some of them is to disclose, and so and so and so. So have a look at the booklet 3, because it shows you what the patient's expectations are. If you've got a patient that takes a call during your therapeutic time, firstly, that person shouldn't be a patient of yours, but secondly, what are you doing allowing that in the first instance? Did you set the tone that this is a therapeutic protected time where you expect the behavior to be A, B, C, or D? Now, a lot of these times where we see a pneumothorax happen, I'm told our patient was lying prone or lateral recumbent. For 20 minutes, they had 9 to 12 needles in them. And the doctor got up, or the practitioner got up from time to time, twisted the needles, went out to get a coffee, came back. You're looking for trouble. try and not look for trouble, because, you know, when you look for trouble long enough, trouble finds you. Yes, you should be recording the type of needles you use, the length of the needle, how many needles you used in your notes. You should also be making a note if there was an adverse outcome or if there was pain. Patient yelled and said, ow, felt pins and needle in toe. Useless for me. Which toe? Was it the big toe? Was it the baby toe? Was it the left side? Was it the right side? Because recent Supreme Court judgments have said, if it's not written, it didn't happen. And it's impossible to defend you well if you haven't written down the journey and the experience. So you don't have to write, use needle for upper trap, put it into sharp spin, used second needle for rhomboid. But if you're using a particular type of needle, say I used a Brad Inc. 25 needle, sterilized, single, using dynamic needling technique, upper trap in sitting, rhomboid in lateral recumbent, using pincer technique. Be as specific as you can, and you can use nomenclature and shorthand, but don't just tick or do needle assessment NAD line through, because I can't defend you if you've got that kind of note.
So Bruce, that is what needs to go into the notes. Surely you should have some sort of a safety protocol in place as well. In case something happens, what do you do?
Yeah, look, it's entirely reasonable to expect that individual practitioners and practices have standard operating procedures in place. And that speaks to not just dry needling, but all the interventions that you get, and maybe even to your fire escape plans. So you certainly should have a policy and protocol in place for how you would implement your dry needling, and then what to do in the event that some complication should arise. You know, if the patient should faint, and I mean, it's the risk of fainting is about 0.02%, but it happens. What happens when it happens? I put the patient flat, I raise their feet, loosen their clothing. That sort of thing should be written down and kept as part of your practice policies and procedures. You need to be prepared before the event happens, so that when it happens, you know what to do and your staff know what to do. Just a quick dig at Brad there. Don't needle rhomboids in sitting, because when the patient falls over, they will be injured. So keep them in well-supported positions, supine or side-lying, prone very occasionally, but avoid sitting if you possibly can. Loads of folk get hurt when they bail off the chairs. It's not okay. Needle them in well-supported positions.
Love it. And,
Brad.
And that goes into, what are your standard operating procedures? Do you have a bucket in your room? So what happens if a patient throws up? What happens if a patient has a seizure? Do you have a second room? How do you run recovery position? What are the emergency numbers? Do you have, you know, these are real things. And what Bruce is saying is true. Now, my recollection of 5 minutes ago is I said needle upper trap in sitting. And Bruce says, I'm taking a dig at Brad. He said needle rhomboids. Which one of us was right?
The recording.
The reason that I say this, and I love it, and Bruce, thank you, and I'm hoping you're right and not me, is if we can't remember after a few minutes what we said, how can you remember after 4 years what you did? And this is a standard approach when we challenge somebody to their therapeutic technique. We said, you know, what did you what socks did you wear? What color socks were you wearing 3 weeks ago on Tuesday? Because they say, yeah, I remember that patient really well from 2 years ago. So, oh, well, what socks were you wearing 3 weeks ago? No, I can't remember. And how do you remember that patient? You're seeing 10 patients a day, every day, 5 days a week, for 221 days a year. How do you remember that patient at that consult? Show me your records. So the accuracy of your record is really, really important. So your standard operating procedure, your safety procedure, is your standard operating procedure. And that is from when a patient makes a booking till when you discharge them from care. How do you manage this? And how do you manage it on an ongoing systematic basis? And think about it, how would you like to be managed? Or if you had a young child who you were treating, or if it was your young child, how do you want that brace to be done? Because when you do it wrong, it gets difficult. And so the question that came through from, I think it was from Philip, is the question, when should I notify? Now, contrary to what anyone hears anywhere, you're always going to let your insurance partner know twice. The first time is when you become aware of a concern. Now, that could be on the day of the notes. On the day of the notes, where you've treated somebody, you might write in your notes, worried about Brad, he was dizzy when he stood up. Worried about him, he complained, he had a little bit of a dry cough, said he wasn't feeling great and went home. You record in your notes, in your section of, holy crap, I'm worried. And you can call it an HCIW note, like a SOAP note, subjective, objective, assessment and plan. You can call it whatever you like, but you need to record it in your notes. If you've got an index of suspicion, notify your carrier if you have a carrier. Notify them and say, I'm worried about the treatment that I did on Brad. And I'm worried about it because of A, B, C, D, and E. That's part A. Part B is when you get the request for your records, which comes from the plaintiff attorney. My attorney calls up and says, Bruce, I believe you've been a bad boy. And Bruce says, oh, no, I'm great. He says, great, send me your clinical records for your treatment of Brad from 2018. And then the blood goes out your face and your chest pain starts. And once they've paddled you and you've been resuscitated with the AED, you try and find notes. So that's the second time you notify. And then your team kicks in. So depending on who your carrier is the broker doesn't support you through this journey. Your carrier does. And they have a group of internal attorneys and they have a group of external attorneys and medical legal people. And off we go down the journey of then reviewing. And before anything happens in terms of what the settlement looks like, because the question is how often, how much is the settlement? And the settlement is anything from nothing to 5 million rand per event in the context of this conversation. In the context of others, the highest settlement for a medical negligence case in this case, in this country is 37.5 million. So somewhere between those two is where the plaintiff attorneys play. But before we can establish quantum, we have to establish merit. And merit is based off, was there a consent form? Was it signed? Were there clinical notes? Were they thorough? Is the patient's description of their experience plausible and reasonable against the reasonable practitioner's test? And the plaintiff attorney, the patient's attorney, does all of this before they ask you for your notes, because they're not going to do any work if they don't believe they can win a claim. So you can be sure by the time you get a request from a plaintiff attorney, they're already fairly sure that they can win, because they're usually on something called contingency. And contingency means no win, no fee. So they're already seeing money coming in, otherwise they wouldn't be calling you. Does that make sense? I hope so.
Yeah.
So merit is your notes. So if you don't have good notes, they have merit. If you do have good notes and you do have a standard operating procedure, as Bruce described earlier, that includes your safety and your communications plan and your documentation, the ability to defend you is much greater, which means the merit that they have is much lower. And if it doesn't go past that, it almost never goes into quantum. If they have a case because you didn't take notes, or you didn't sign consent, or the consent form is signed by you and not them, or by your receptionist, which I see sometimes that the consent form only has the receptionist's signature and not the patient's signature. Like, no, then there's merit.
No.
The whole practice was negligent. You were reckless. And then there's no way to defend you. Then it's just how much do they want and how quickly can we set.
For sure.
Yeah.
Bruce?
Ronnie, back to you.
Yeah, I just noted there's a question there from Philip again with asking for some more details or more references about the minor, transient, and serious breakdown. We're going to reference in the show notes, well, in the chat box, a paper by somebody called Boyce, B-O-Y-C-E, 2020, and that should give you the details that you need. That'll be in the notes just now for Philip.
Great. And then the question was asked, hard clinical note. A contemporaneous note doesn't have to be handwritten. In fact, I'd prefer, in my perfect world, no one would write notes by hand, because we take pride in being illegible and incomplete. So a digital note on a system that records and archives when you made the note is great. So if you're on an electronic medical record system, I don't care which one it is. I'm agnostic. I know I use Clinico because I've used it since its inception and I like it. I also like it because it tells me if I haven't done a note, and then it date stamps and shames me. It says this note was done at this day at this time. So I know that if somebody's going to come looking at my notes and my note of the 8th of February was for a consult on the 2nd of February, I'm dead to rights. So I make a habit of doing that. So your clinical notes typed, stored, encrypted, and on your server is fine as long as you've made sure that you've got two-step authentication. And Lonnie, if there's time, a quick story. I got a telephone call once.
Sure.
You can imagine this. I get a call and they say, Dr. Beira. I say, yes. They said, this is Inspector so-and-so. You can imagine. You know, you don't even go cold. That heat at the back of your neck starts to come. You get this instant sweat. Yes. They say, well, we're calling you because your name is on this handset that was recovered and yours was the last call. And we've got a whole lot of patients' names and patient records on this phone. So just make sure, not only under the confidentiality and disclosure aspects of the ethical guidelines, both on Allied and HPCSA, understand that under POPI, you have to take every step to ensure that your notes are protected and encrypted. So you need to, if you're doing digital notes and you're using multiple devices, at least have a two-factor authentication.
There's a question that keeps coming up. Sorry for interrupting there, Brad. The question around payment. If something did happen while you were dry needling, do you still bill that patient? Is it an admission of guilt if you don't? And I'm sure it becomes a bit of an ethical dilemma at this point.
It is, and it's a personal choice. Would I charge somebody who was having a side effect that I may or may not have contributed to? Probably not. But I don't have maybe the same debt ratio or commercial ratio as anyone else. We're all different, right? My general sense is relax and take it on the face value. If it's a very minor bruise or a bleed that you're using a cotton swab or they're a little bit itchy and they've had some kind of erythema or they felt a bit giddy afterwards, no, that's in the normal course of therapeutic care and you've explained this to them beforehand. If they've developed a neuropraxia or they have a pneumothorax or there was something more severe, I would generally say to them, let's see how everything goes and make a billing decision second. And this is where I think some big problems happen. Most people, when we did fairly big studies early on in the medical legal journey in this and other countries, their issue wasn't around the discomfort. Their issue was around the financial implication. They just got mad. And they got mad and they said, well, there was a bad consultation, regardless. And so because it was a bad consultation, why are we paying you? And then they get irritable. And then they sit at a dinner party and they say to somebody else, oh, you know, I saw Brad and I was quite sore afterwards. And the worst thing was I got a bill from him for that. And that then leads to somebody else saying, yeah, and that's terrible. And you can do blah, blah, blah. And so be aware of that. That's a discretion. Billing somebody or not billing them is not an admission of guilt or an admission of anything else. It's an admission of your billing practice. And so your informed consent form on your patient contract, and I know that ProfNet and Specimen have great ones, speak specifically to what is your billing contract? What is the obligation of the patient? And under the National Patient Rights Charter, one of the obligations of the patient is to pay for their consultation. But you've got to look at that and consider it within the context of that therapeutic engagement and what's happening.
Yeah. But Brad, do you know, and you might not be the best person to answer this question, does it affect your liability cover if you don't charge the patient? Or if you do, and something went wrong?
No, they're two completely different things. I can say, so in my practice as an example, I don't charge 70% of the consultations of people who come in because that's the kind of work that I do. I work with groups of people who can't pay my consultation fee. So they pay me with a candy bar, or they pay me with a succulent plant, or they pay me with a piece of cake. That doesn't mean that my therapeutic diligence is different. And so if you choose not to enter into that commercial fulfillment, it doesn't mean you are liable or you're acknowledging guilt or debt or accountability. You're simply saying, I used my discretion. And my discretion was that I didn't feel like charging you. It doesn't affect the defense. It doesn't acknowledge a recklessness. It doesn't infer guilt in any way, shape, or form. And it doesn't diminish the medical legal team's ability to defend you because you chose not to bill. I think that that's a fiction. And it's a fiction, unfortunately, that we see across the market sometimes.
All right. I think we'll take one more question, then I've got a question as well. Bruce, there's a question from Ashna with regards to needling a minor and consent. Do you require both parents, single parents? What happens if it's divorced parents?
Yeah, so a couple of things about needling minors. Now, first of all, don't do it. Children don't do nicely with needles. The very few minors that I've tried to needle tend to be high achieving athletes. And in which case you need the consent of the patient and the assent of the parents or guardians plus witnesses. So it's a little bit more of an involved procedure, and Brad would probably speak better to that than I would. But from a clinical perspective, kids don't do well with needles unless they are really bought into the process. So they are national level age group athletes, those sort of things, not your run-of-the-mill kid.
Brad, anything to add to that?
Yeah, look, there's a couple of things that I'd like to add, and you know me, I can take a simple thing and make it complex really fast.
We just need to watch the time.
The first is don't needle minors unless you absolutely have to. The second is any minor under the age of 12 needs consent from parents. The third is any minor over the age of 12 under 18 needs to be present and part of the consent process, but I still wouldn't needle them unless it was really important. The last one, which comes up from time to time, is if you're treating the child and one parent brings them in and the parents are divorced, you need to consider how you keep that therapeutic dialogue going with the other affected parent, because that can lead to some significant difficulties around consent. The dad consents and the mom doesn't. The child goes from one to the other, and then there's a break in care, and the other parent won't bring them, and suddenly the child says, yeah, and he put a needle into me. And off you go down a journey that's very hard to defend. So if you're working with a minor and the parents are divorced, you need to make sure that you're having dialogue at least with both parents if there's a co-parenting relationship. So be aware of that.
Brilliant. Thank you. Bruce, a last question from me. It's a clinical question, a bit of a random one. How long after surgery can you do dry needling on a patient?
Yeah, as a general comment, what you want to do is find out why you want to put the needle in the first place. If you're doing it for simple pain control, then shortly after the surgery would be fine, and then you'd be doing a superficial technique only. But if you're going to be going in for intramuscular needling post-surgery, the patient's going to have a reason to have pain, and I'd rather have therapists respecting the stage of healing at that. Leave the poor patient to heal for 6 weeks at least before you start fiddling around with the healing process. A couple of issues around there as well. What about arthroplasties and implants and ORIFs? I don't think there's any indication to needle around those areas in the acute situation. Again, respect stage of healing. In a healed patient, 3-4 months down the line, there is no evidence of any infection or adverse reactions with ORIFs at all. So my answer would be, for post-surgical, decide what your intervention, why you're doing it, what's the clinical reasoning, then take cognizance of stage of healing and only intervene if something non-invasive isn't going to work as well. Always go for exercise, movement, and advice first, and needle as a secondary.
There you go. Easy answer to that one. Guys, thank you very, very much. Just again, for any of the attendees that are interested in the dry needling standards, I'm pasting those 2 links into the chat functionality as we speak. You can copy it from there and use it at your own discretion there. We do need to start wrapping up, however. I sincerely hope that everyone here today is sort of walking away from this webinar with more information and a couple of risk mitigating strategies that you can apply and implement in your practice. I see Michael Demant from Genoa actually pasted the medmal@srisk.co.za email address in the chat functionality. If anyone on the call today have got any MPI, broker or insurance related questions, please contact them. If you've got any ProfNet membership related questions, please contact us at info@profnetmedical.co.za. I will put those two email addresses in the chat functionality in a second as well. Let's just go back to our two guest speakers. Bruce, perhaps a last thought from you, and then Brad, and then we'll wish everyone goodbye.
I think we're tremendously privileged as therapeutic practitioners to be able to use techniques like dry needling. Don't abuse that by screwing up the technique. Respect your patient in the first instance, build a therapeutic relationship, and do your best for the patient at all times.
Thank you, Bruce. Brad, a last thought from you.
Yeah, just a reflection on some of the things about record keeping and consent. It's a privilege to treat people, not a right. We study to give us the access to be able to exercise the privilege.
Yeah.
Using a system like an EasyMed system that allows you to do good record keeping, to have your informed consents ready, to have your documentation and your communication and compliance good. Listening to these kind of programs with people like Bruce Lonnie and yourself who's sharing the information, and to those of you that have asked the questions, this is the fundamentals of how we stay as good practitioners. So thank you for the privilege. Reach out anytime. I know that from our panel, it's been great. We've put a lot of effort into getting this right for you. I hope that's come across. Thanks, Lonnie.
Wonderful. Bruce, Brad, thank you very much from my side as well. We have run out of time, so that is all from us, folks. Thanks again for participating in the webinar. Please, participants, keep an eye out for some of our future webinars, also relating to reducing and the management of risk in your practice. But until then, please be safe, take care of yourself, and have a very pleasant week ahead. Take care. Bye-bye.